Good morning. Today I will present an educational innovation project focused on redesigning how informed consent is taught within pediatric dentistry clinical training. This proposal emerged from empirical evidence gathered within our university clinical setting and was conceived and developed by the academic team of the teaching unit of orthodontics and pediatric dentistry. Its purpose is to transform an implicit clinical competence into a structured, observable, and formally assessable learning outcome. Before discussing our educational redesign, it is important to clarify what we mean by informed consent. Informed consent is not merely the signing of a document. It is a structured communicative process that ensures voluntary decision-making based on adequate understanding. It requires the explanation of diagnosis, benefits, risks, therapeutic alternatives, and the possibility of withdrawing consent. In pediatric dentistry, informed consent is not merely a legal formality. It is a complex communicative process involving three actors: the practitioner, the child, and the family. Unlike adult settings, information must be adapted to the child's developmental level, respecting the principle of progressive autonomy. A previous observational study conducted in university clinics revealed an important discrepancy. While students frequently explain diagnoses and benefits, the communication of risks, therapeutic alternatives, and the possibility of withdrawing consent was considerably less consistent. This indicated a structured training gap. Although informed consent is theoretically addressed within bioethics modules, its clinical application remained largely unstructured. Students appeared to rely on intuition rather than protocol, resulting in variability and omissions. This competence was expected, yet not explicitly taught nor systematically assessed. The aim of this innovation was to transform informed consent from an implicit expectation into an explicit pedagogical objective. Our goal was to reduce variability, reinforce ethical clarity, and promote patient-centered care grounded in progressive autonomy. The redesign is structured around four complementary components. Together, they create a coherent pedagogical framework integrating theory, simulation, formative assessment, and structured clinical application. The first component is a mandatory structured checklist embedded within the digital clinical record. This tool ensures that essential elements, particularly risks and alternatives, are not omitted during patient communication. Simulation-based training allows students to practice adaptive communication in a safe environment. Scenarios vary according to developmental stages, enabling structured rehearsal of triadic interaction between child, family, and student. An analytical rubric was developed to objectify communicative and bioethical competence. Rather than evaluating documentation alone, the rubric assesses clarity, proportionality, and ethical coherence. Brief micro-learning capsules are delivered prior to clinical sessions. These concise theoretical reinforcements help students integrate bioethical principles directly into real clinical practice. Implementation followed a phased approach, ensuring coherence and feasibility. Faculty calibration was essential to standardize supervision and evaluation criteria. During the pilot phase, we observed improved consistency in consent communication. Students demonstrated greater awareness of risk explanation and therapeutic alternatives, alongside enhanced confidence in managing communicative complexity. The innovation is structurally simple and easily transferable. However, further work is required to strengthen inter-rater reliability and to generate robust, longitudinal quantitative evaluation data. Ultimately, this proposal redefines informed consent from an administrative formality into a structured professional competence. Importantly, it demonstrates how empirical research conducted within the university context can directly inform and enhance curricular innovation. The model is readily transferable to other health-related degree programs in which ethical communication and shared decision-making constitute core professional competencies. Thank you very much for your attention. In closing, I would like to emphasize that strengthening informed consent in pediatric dentistry is not simply a matter of regulatory compliance, but of professional identity. By transforming this process into a structured and assessable competence, we aim to foster clinicians who are not only technically proficient, but ethically reflective and communicatively responsible. This project illustrates how evidence generated within our own clinical environment can meaningfully inform curricular redesign, reinforcing the alignment between research, teaching, and professional practice. We hope that this model may contribute to ongoing discussions on ethical communication in health professions education and inspire similar initiatives in other academic contexts.